there's any questions, we are here for you. Question right here.
She got a job after UPenn with Big Pharma. She was making good money. You know why she quit? Now she's in medical school. She doesn't like the competition. Pfizer is hiding this from the other one. You know I'm going with this. They were shocked when she gave her resignation. Now she's in medical school. She said, why don't we collaborate? I know it's not coming from the medical side, but why doesn't Pfizer, if for the good of humanity, communicate with Johnson & Johnson and Janssen, because she was working for Janssen. That's what made her so disgusted, even though she was making a good salary. She said, I don't want to be in that competition. So I don't know if you have any insight or if there's any way we can fix that problem.
I'm going to say, since I'm the most outspoken person at the table, I think I should probably touch this hot iron. And again, if anybody has anything to add or subtract, to be honest, it comes down to profit and it comes down to competition for the drugs. Now, I want to say that there's being old enough to remember in the 80s and during the AIDS crisis, that there were ways to break down these barriers, to create combination therapies that were combined drugs from different companies. So it is possible, but I do think that it's what we all suspect it is, and I would love to hear if anybody has any other opinions. We have collaborations with drug companies all the time, but I understand what you're talking about is in between the different drug companies. Yep, nope, we eat it every day.
Hi, sorry, I have a mic. I'm Leslie. Hi, I'm from City College. I'm a graduate student along with my two other classmates. I just have a question for Dr. Gonda. You mentioned that there's a need for high quality equipment to detect smaller lesions. How does underrepresented facilities acquire new technologies or improved technologies? Who is approving these purchases, and how does that whole system come about?
That is an excellent question, and I think it's I would emphasize that you need standardized equipment, perhaps high quality standardized equipment, and there is no reason that our equipment should be different. These are not experimental methods for imaging. Both of those modalities that I showed are standard of care modalities. I think perhaps I would emphasize that the high quality is very important. Interpretation and sort of specific attention for screening is what we have learned to be the most important thing. So it's not, and on that level, I'm not even sure it's at the sort of the first step is to understand that you're doing the imaging study for a screening purpose, which is very different. When a radiologist looks at an MRI, when I do an endoscopy and we look at those procedures for a specific indication, and that indication is, let's say, just as simple as abdominal pain or some disease entity. Your mind focuses very differently on the organs that you're not actually being asked to look at. So the classic example would be that if you're looking at, let's say, does somebody have a kidney stone? Okay, the radiologist's review of the pancreas will be very different than if you put on the notion that this is for pancreatic cancer screening. And I think that's where I actually think standardization and, to a large extent, AI-based approaches will be incredibly helpful, because the AI doesn't care. It still remains a little bit of a black box. You don't know what it is looking for, but it will pull out features equally between a patient being evaluated for a kidney stone, abdominal pain, or for pancreatic cancer screening.
So for the AI, is that easily integrated in your workflow, or are there any challenges that you faced with that?
it's actually remarkably easily potentially integrated. Very few radiology reading currently integrates it, because it requires, I mean, it does need to go through various approval processes and whatnot, and that part is not simple, but to integrate it into your practice or integrate into a radiology practice is very easy. So I now use it routinely in procedures in the sense that, you know, I quote unquote turn it on, and that's, I mean, it's very simple and very easy to use.
I have a question for Dr. Habowski, right? Celeste. Okay. So you mentioned something around pharmacotyping. Is it something that we should be expecting to happen in the near future?
That's a great question. So just to iterate, what we call pharmacotyping is basically where we take those patient-derived organoids and we do drug screening on them. So we look to see where they're more sensitive or more resistant. So we potentially think it could be something that's useful in clinic. And that's something that we're working on actively. There's some challenges in terms of how long it currently takes us to get drug screening data. So we're trying to develop more rapid approaches. And we're still from that past trial trying to really determine how helpful is it. So potentially this could be something, you know, years down the road that you have, you know, part of your tumor sent out for sequencing and you have part of your tumor sent out to have drug screening done on it through an organoid model. So there's potential, but we're not there yet.
There was a question. Yeah.
So I don't have a question, just comments. So one, I wanted to commend you, Dr. Habowski, and the overall team, just for looking not only at the Black population, but also more deeply into the different ancestries within, because I think that's really important to properly represent the heterogeneity. And then my other comment was to what you said earlier. I'm sorry, I don't know your name. Yeah. So I am actually here representing Bristol Myers Squibb. I work there currently. And I'm definitely in the
I'm in trouble now.
No, I'm definitely in the same position in which I do also wish that there was more collaboration. But again, most things are driven by profit when it comes to these companies. And so I see firsthand, and I've been on both ends of the spectrum, being in academia and also in industry now, that certain things aren't shared because they want to be able to make money. Yes, it's driven by helping patients, but the goal is also to make money and to please investors, unfortunately.
She's taking loan. I paid for my husband and I repaid for her to repent. That left me penniless. But now, because she doesn't like the practice, she has to take a loan. This one, there is something else that we need to address it. That's nothing to do with fun. We need to address it.
Okay, next question. Thank you. Yes, go ahead.
I have a more research-focused question, and it regards the progression from IPMN to PDAC. There is some, I'm assuming there's some, it's similar to what happens in breast cancer when you don't know which DCIS is going to progress to an invasive ductal carcinoma. Are there any clonal evolution studies? Because I'm assuming there are patients that came to the hospital, had their IPMNs removed, and then later on came and then had PDAC and then also had that removed or for some biopsy. Are there clonal evolution sequencing studies that are looking at those matched samples and seeing if there is something about those IPMN that is predictive of progression to PDAC?
Yeah, so there's a lot going on now that I've heard about, but I would cite, and I hope again to get some other input, that some of Chris Akabuzio-Donahue's work from a few years ago, looking at the shared mutations within clones of the primary and shared mutations with the different metastases to be able to trace back where it's coming from. And if you look into some of those papers, it's a lot more complex than just the clonal selection. But any other comments there?
It's a great question. It's a different pathway than what I mostly focused on, and it sort of takes up the majority of my clinical practice to try to understand who are and what are the cysts that we should worry about. There is there is a great deal of data, and for sure, as Dr. Crawford mentioned, in terms of clonal evolution, it's actually much more complex and diverse than I think many of us thought. We all thought that, you find the big cyst, that cyst will become a cancer. If there's 4 other cysts that are whatever 2 millimeters, those you can kind of ignore. As it turns out from some of the work that has recently come out, it's not nearly that linear. At the very least, I think there are some emerging biomarkers that allow us, from whether it is cyst fluid or from pancreatic juice or something, that to pick up some markers that give hope that you can actually pick up a precursor cyst lesion that is at risk.
Right there.
Hi, I have a question. It's a 2-part question. First to Dr. Gonda. Coming from,
Could you speak louder?
yes, I will. I have a 2-part question. The first part I'm going to address to Dr. Gonda. So coming from an institution like NY Langone that is well endowed, but it's also a teaching institution, what are your takeaways that you pass on to your residents and your fellows, especially those that are going into the community, working in facilities that are not as well endowed? That's part 1 for you. And then for everyone on the panel, what do you know now that you wish you knew 10 years ago, and how would you put it into practice in your respective industries to make it standard for care for everyone?
That's a very good and difficult question. In this context, in pancreatic cancer screening, my sort of one and perhaps only message to the non-specialist trainees that we work with is to start thinking about it. And that's different than, I think, even 5 years ago, but certainly 10 years ago, when nobody thought about screening for pancreatic cancer. So I think one of my sort of goals, in terms of, if you want to call it educational goals, is to at least put it out there on providers' radar that this is something that you should think about, and that this is something that you should identify in patients. And part of the kind of motivation behind doing this work with, essentially developing a system that sends somebody a red light that says, you know what, this person may be at risk for pancreatic cancer, you should think about screening, was to kind of facilitate that process.
Okay, we're running out of time now. Okay, we'll take one question. Dr. Baines, go ahead, Dr. Baines first.
Well, I'll relay it to.
Okay, make your question short, please.
Thank you. I would like to thank all 3 presenters. My name is Kyriaki Funda. I'm a PhD student at Northwell Health. So my question is for Dr. Crawford. Very interesting study. I think you touched a little bit on that. So I think my question is more towards the immune cell infiltration. Of course, it's difficult to do any type of deconvolution because of the reason that you mentioned. So we use gene expression signatures that are derived based on individuals of European ancestry. But I'm just curious if you have like any type of tumor purity for your patients, and whether you are able to understand. So you did mention that there are some differences in the B cells in the tumors, but I'm just wondering if it's not just a difference in the immune cell type, but actually in the immune cell proportion within the tumor, if there is differential immune infiltration, like the proportion of immune infiltration between the more basal-like and classical-like tumors. And like another suggestion, maybe since you mentioned that you have low sample sizes, an idea that I had is maybe if you try to model like the tumor purity and the estimates of immune infiltration on the percentages of basal or intermediate or classical type tumors. And just like try to figure out how maybe the immune infiltration interacts with the tumor cells, and you see this kind of different tumor cell types.
Yeah, so that's a great question, and I think you're absolutely right. I can say really quickly that the mouse model suggests you're absolutely right. That's one thing, but one of the things that came out of the analysis of the single cell atlas that Nina put together was that fibroblasts making CXCL10 were more associated with the basal subtype in pancreatic cancers, which if you go down the rabbit hole a little bit, that also meant there'd be more T cells in the region because CXCL10 is usually turned on by interferon gamma, which is coming from T cells. So I think there's absolutely a relationship back and forth, not just one direction from the basal brings on, these fibroblasts, these T cells, but those things are influencing what is the subtype of those cancers. And absolutely right. It's a burgeoning field. It's very young. But again, the mouse model suggests that there's some real direct relationship between the immune response and the subtypes that are occurring.
Thank you.
Dr. Baines, last question from the audience.
Good one to close it out.
Yeah, I'll close out. So again, awesome panel. So I guess the question is going back to the differences you see in East Africans, West Africans, African Americans. So is that suggesting there's some environmental component that's explaining these differences? And then this may sound kind of weird, but have we looked at European populations, different groups, and do you see these similar differences as well? If you look at different, types of Europeans, just curious.
Yeah, I mean, I think one of the challenges is deciphering the effect of socioeconomic factors, the lived experiences, and the genomics molecular aspect. Yeah, so I think, it's both. I think my research is more focused on the molecular aspect, but that's why we need both aspects of research because they're obviously both playing a role in the health outcomes. I don't have a great answer for the diversity within European populations, but there's probably been studies that have been done, I imagine. I think one of the differences with the European population is they're a lot more closer and condensed together, whereas Africa is a very large continent. So I think some of the genetic differences are maybe more disparate in the African continent, but we should definitely look, and maybe that's kind of a comparison we can use to look at. In our genetic ancestry, though, we do have different regional differences in the subcontinental breakdown. So we do have some differences in there, like Great Britain versus more Nordic versus not. So there is some there, but we haven't really focused on that yet.
I'm going to throw one thing in there. I also mentor somebody who's an African researcher looking at breast cancer and different parts of Africa. And one thing that's interesting is, for instance, the expression of TLR9 in certain regions and TLR9 is associated with the response to malaria. And so, and the malarial connection is associated with which region we find it. So,
okay.
Right.
I think we should take one question from the chat box. If you can turn around and read it. I don't know whom it was directed to. It says, how is there a high risk when patients are entered into screening? I don't know whom the question is directed to. How is there a higher risk when patients are entered into screening?
So
maybe Dr. Gonda, maybe.
Yeah, I think the entry test is a genetic test. You're defined as a higher risk individual based on your family history, and some of this is the terminology, but if you're at risk for pancreatic cancer based on your family history, your first entry test is a genetic test. And that determines whether you should continue with screening or perhaps actually the risk is low enough that you should not.
All right, so please join me in thanking the speakers and panelists for a wonderful job. Okay, so we are now maybe 5 minutes to closing and closing remarks. But before we go to the closing remarks, we have 3 awards we want to present, marking the 10th anniversary of this symposium. As you must have heard in the morning, we've been doing this for 10 years, and there are 3 people who just stood up. They just stood so clearly as the pillars of this conference, and we want to honor them for that. Dr. Tuverson, you want to come forward? Dr. Tuverson is my partner. We are co-sponsoring the symposium. Let's see. Dr. Baines, could you come up? And you can give him this award and then read it as well.
All right, thank you, Dr. Salufa. So the first award is going to go to Professor Antonio Baines. In recognition of his unwavering support as vice chair of the EAB for the SUNY Downstate Cold Spring Harbor Lab, Stony Brook NIH P20 grant and collaboration over the last 10 years. He's been a terrific partner. Thank you so much for your leadership.
Maybe you should give the second award too to Dr. Caritas. He's on, I think he's on the,
Okay.
Yes, I'm
It's on the
online,
Zoom.
but the camera, I can't see.
right
him.
here.
Dr. Carruthers is the handsome looking fellow on the top screen. There you go. So he's actually, he has a very high title now.
Really big, really big.
Dean.
Not as high as you, David.
Higher than Dean.
He's
Vice Chancellor.
Vice Chancellor.
This is like next to God. Okay, so in California, he's unbelievable supporter of ours. So Professor John Carruthers, in recognition of your unwavering support as chair of the EAB for the SUNY Downstate Cold Spring Harbor Lab, Stony Brook NIH P20 grant and collaboration for this past decade. Thank you again for all of your support, Dr. Carruthers.
Well, I thank you, and thank everyone at SUNY for really driving research in this area. So thank you.
You're very welcome. Thank you.
And then my partner, Professor
Salih,
is going to give the last word.
Okay, so this is not surprising. Laura Martello Rooney, come up. In recognition of your tireless efforts organizing the annual Cancer Health Disparities Symposium for the last decade. Thank you so much, Laura.
Let's take a picture. You stand up. Let's take a picture. Do a picture with
Congratulations, Laura.
Thank you.
So we're gonna try to take a picture. We're gonna shop you in though.
Shop you in.
But you should watch this. You should watch this. Yeah.
Just to let the camera is only pointing to the empty chairs. I can't see you.
I'll just say a few, then I'll.
Yeah, you could do the closing remark.
Okay, so I want to thank Dr. Salufo and Dr. Martello Rooney for hosting this event. Once again, it's been 10 years now. It's an extremely important topic that 10 years ago, we knew a lot less, I would say, as to why there might be a disparity in colon and pancreas cancer. We're getting closer because we're seeing clues now about the biology of the disease. And we also have a much more organized way to try to disentangle the many factors involved in the social determinants space. We've learned how to measure things. We've learned how to communicate with each other. And that's really the critical thing. I think the next 5 to 10 years, we're going to really boil it down to what could be the molecular clues that link to how people live. That will be relevant not just for these diseases, but for health in general, I would say. So that's why this is a profoundly important topic. And it's going to take pragmatic approaches coupled with passion, as you saw some evidence of today from multiple people here, to get us even further. I mean, there are populations that have a much higher risk of pancreas cancer that we're not even talking about. I mean, you think of native Pacific Islanders, this is double, right? So they have like a tremendous amount of pancreas cancer, and we have no idea why, because there just have not been deep studies. It's very challenging to actually get into that topic. Even though I've gone over to Hawaii a bunch of times and tried to work on this, it's very, very difficult. So I think that whatever we learn here will be impactful elsewhere. And again, that's the really terrific thing about our partnership is you've allowed us to lean into this topic from a very basic science laboratory on Long Island. And so I want to give Dr. Salufo really again a round of applause, him and Dr. Martello Rooney, for supporting work in this area. And now we're going to hear from Dr. Salufo.
Well, I don't have much to say. I'd like to thank all of you for coming. The honorees, Dr. Tuvison, my partner, you, the audience, those online. We hope to see you next year. Again, the reason for this is to create these collaborations, partnerships, connections, networking. So I hope that, you know, this kind of symposium would energize you to take the message forward to your colleagues who haven't been able to make it. And hopefully we can get better science, better treatments, better ways of treating our patients, and hopefully from bench to bedside in the future. So have a good day.
Thank you.